triage nurse what the paramedics told her about Mr. Tolson's injury.
Objection.
Objection, forming foundation.
If she felt that she couldn't get a reasonable history from the patient, then yes.
Okay. Now, what history did Ms. Shaw write in the medical chart?
Her chart, and I'll have to find the exact page, but basically, in fact, even her deposition, she is just,
Page 11, Doc.
11, she's talking about a door having injured the patient. You caught up in a barrier door.
Okay. I think according to her testimony, she believed there was an overhead door that came down and struck him on the knee.
That was the description that I kind of walked away with.
Is that different from what we now know as to what happened to Mr. Tolson's leg?
Well, I will tell you that having read his deposition, I'm still not 100% sure. You know, I don't have a good idea of what transpired. It seems to me like some barrier comes out of the ground, and then I could understand that. But then when I looked at the paramedics and they're talking about movable boxes, then that to me doesn't make sense as far as you know, what's going on. And then you, just a few seconds ago, talked about a fence. And so I'm not sure in my own mind exactly what transpired.
When you say that his foot got stuck inside a movable box, could that word box also be gate?
Objection.
Objection.
You seem to think it's a box. Could it also be gate?
Objection.
Gates.
Foundation.
Objection.
Is that one reasonable interpretation?
Don't speculate.
I can't. I don't know what that.
Would it be fair to say you just don't know what that word is?
Objection.
Objection.
I viewed it as boxes, but it may be gates. I can't tell you.
Okay. Well, we do know that from the paramedics report, his body twisted, correct?
His body, it says his body twisted and he fell to the ground.
And it said that all the pain is in his left knee.
Correct.
Okay. So we know at least his body sustained a twisting injury, an injury involving the left knee.
Correct.
Okay. Is that history, would that be something that would suggest a possible dislocation to the knee?
To me, no.
Okay. Why not?
Because dislocation of the knee is a very, first of all, it's not a very uncommon situation that presents in a community emergency department. This would be usually seen in high-speed automobile accidents. You can see it in certain sports activities. Right now, you know, it's downhill skiing. You know, high-speed injuries. It occurs with falls from heights. These are usually high-impact injuries. The Joe Montana injury, where he fractured, could conceivably be a situation where you would get a dislocation. Something that is a person gets his leg caught and twists, that is not anything that would raise my suspicion of a dislocation. We see lots and lots of knee injuries, and very, very few are dislocations. And in fact, I would be surprised if the EMTs, if they thought they were dealing with a dislocation, would have taken this person anywhere but to a trauma center.
Is St. Agnes Hospital a trauma center?
No.
It's not. Doctor, did the defense attorney show you any videos of a fence going up and down and a body being trapped in a fence?
No.
Objection.
Did the defense attorney show you any medical animations that we provided to them regarding the mechanism of injury?
No.
Okay. Would you have liked to see that or not?
Objection.
No,
Objection.
I wouldn't, because the standard of care is what one what the doctors and the PA can elicit from the patient at the time of the evaluation, not something that is artificially produced later.
Okay. Now, is it preferable that a physician's assistant obtain a history and mechanism of injury from the patient before the patient is administered narcotic pain medication?
Objection to the term preferable, but you can answer.
That would depend on how much pain the patient is actually in, whether they're willing to even talk to you, or they're saying, my knee is hurting too much. And also, there are some people, you give a certain amount of analgesics to, and they can be almost sedated. The next person, they're saying, I need more pain medicine. So it would be on an individual basis as to whether one's subsequent history is reliable after giving analgesics.
Is there any way to know in this case, or do you have an opinion, whether Mr. Tolson's subsequent history is reliable after he was given the 1 milligram of Dilaudid?
Objection.
There's nothing that indicates that he was not a reliable patient.
Do you know one way or the other? Or do you have an opinion as to how the Dilaudid that he was given at 325 affected his ability to communicate clearly and provide a history to Ms. Shaw 25 minutes later?
Objection to foundation.
It's not documented.
Do you have an opinion?
No, I'm working under the assumption that since they got a history and that there's nothing that indicates that that history is not reliable.
Would you agree that there's a difference between the history that the paramedics obtained from Mr. Tolson regarding the mechanism of injury and the history that Ms. Shaw wrote in the chart?
Correct, there is.
Okay. Do you have any opinion as to how to explain that difference?
No, it would just simply be that the two people walked away with differences of opinion, and whether I cannot explain how they came up with that.
And it would be fair to say that the only medication that was administered to Mr. Tolson from the time he gave his history to the paramedics to the time Ms. Shaw wrote the history in the chart was the 1 milligram of Dilaudid.
You're correct.
Now, to obtain a mechanism of injury from a patient, would it be fair to say that it takes about just 5 seconds to ask the patient what happened to you, how you were injured?
Objection.
It could be as easy as 5 seconds. Sometimes it can take longer.
Okay? And for a patient to respond, maybe, 30 seconds, a minute, if the patient is cooperating with the medical provider.
Objection. Don't speculate.
It would vary per individual.
Okay. And in this case, there's nothing in the record to suggest that Mr. Tolson could not adequately respond to questions regarding the history and mechanism of injury.
That is correct.
Okay. Yeah. So if it only takes a short period of time to ask the question and a short period of time to give the answer, wouldn't it be preferable to do that before the patient's medicated?
Objection to
Not if
foundation.
they're in a lot of pain. And in this particular case, I feel pretty strongly that I can predict exactly what transpired and why he was given medication when he arrived, because he was in severe pain, and subsequent, and that was a verbal order from the PA or the doctor, and then when the patient was able to be assessed by the provider, they were at least had enough relief that they could elicit a history from.
Now, when you say you're able to predict what transpired, is it based upon anything in the medical chart, or are you relying just upon your knowledge as an ER physician?
Knowledge on ER and 38 years of experience, that patients come in, they're in severe pain, not so much the triage nurse, but the nurse who's going to be taking care of them comes and says, Joe Blow is in severe pain, can I give him some pain medicine while we get him situated here and before you see him.
Okay.
Yeah.
In this case, you did read Dr. Jackson's deposition testimony?
I did.
You did read Ms. Shaw's deposition testimony?
I did.
Dr. Jackson, in her sworn testimony under oath, denied ordering the dilaudid. You're aware of that?
Objection to the form and the way you phrased that question, denied. Go ahead.
Well, I don't recall specifically whether she denied it or not, but I can tell you that the medical records indicate that she was the one that ordered it. Now, whether she did it or Dr. Krista Shaw, that really doesn't make any difference to me.
Now, Dr. Jackson actually testified that Ms. Shaw ordered the dilaudid, correct?
I believe so.
And Ms. Shaw said that Dr. Jackson ordered the dilaudid? So from the deposition testimony, if you just take their sworn testimony under oath, both physician assistant Shaw and Dr. Jackson denied ordering the dilaudid.
Objection to the term denied.
This
Said they didn't do
represents
it.
testimony.
Clearly, nurses would administer certain medications without physicians' immediate and direct approval. That would be like Tylenol or Motrin or Zofran or something like that. Narcotics are closely monitored and watched in an emergency department setting, and that's in every hospital setting. And the fact is that no nurse administers narcotics without a physician or PA order. And so one or the other gave the order to give this gentleman some dilaudid.
Right, but both of them testified under oath that they didn't. You agree,
Objection.
you agree that that is her testimony under oath?
No,
Objection.
don't
This
agree.
represents
Objection.
the record.
I'd have to look at it specifically to see
Yeah.
Okay.
their exact response to your specific question.
Okay. Doctor, we're going next to number 2, your physical examination.
Correct.
Okay. For a patient with a clinical presentation such as Mr. Tolson, who from the triage record we know that he has a deformity, he's unable to move his left foot, but he has positive pedal pulses. What was the physical examination that was required of Ms. Shaw for the examination of Mr. Tolson in this case?
It'd
Lack
be-
of foundation. Objection for the lack of foundation. Go ahead.
The examination is, it is the same for Ms. Shaw as Dr. Jackson, as would be me if I was seeing this patient, that one's evaluation of an acutely injured knee, it should be the best of your ability, but it's certainly going to be limited by the patient's pain and perhaps swelling. But it would begin with inspection of the knee, whether it's swollen. Then basically you could feel the knee, if not so much this particular case, but if it was warm, indicative of an infection. And then it would be the examination of the knee. Specifically, one would be trying to assess range of motion and then ligamentous stability. Specifically, the 4 ligaments that we're interested in would be the anterior cruciate, the posterior cruciate, the medial collateral, and the lateral collateral ligaments. And there are tests that one can use to assess those individual ligaments. Having said that, it should be pointed out that due to pain and swelling, especially in the acute care situation, that those examinations are very limited.
Are you basing your opinion that the examinations are very limited by the chart, or based upon your experience as an emergency room physician?
You asked me, we weren't talking specifically about this particular case. You asked me what would be the physical examination. So what I was talking about there is the generic physical examination that one would do on not only Mr. Tolson, but every other patient that came into an emergency department setting.
I think I understood it correctly. What you just said, what you just went through, would apply whether Ms. Shaw is examining Mr. Tolson or another patient who presented with similar clinical presentation.
You're exactly correct. What I'm
Okay.
saying is that is what is required of the standard of care. Now we can switch to Mr. Tolson specifically.
Go ahead through the same litany, if you would, with respect to what is required of Ms. Shaw for the examination of Mr. Tolson in this case.
It would be the exact same thing, and in fact, on page 12, we have her examination, and she describes the knee as being swollen, it is tender palpation, and it has limited range of motion.
Okay.
And she also looks at the ankle and leg, but we're not interested in that right now. There is no specific comment with regards to testing of the stability of any of the 4 ligaments we commented on.
Did she ever note the deformity in his leg?
Objection?
No, and I don't think that, in fact, if we go back even further, there is no description of deformity by the paramedics. There's just description of swelling. So I don't know how to interpret that comment by the triage nurse, because there is no description by any other medical source that there was deformity, nor do I think there was one any there.
Okay, so it's your opinion that even though the triage nurse noted a deformity somewhere on Mr. Tolson's leg, that no such deformity existed?
Correct.
Objection.
Okay. The triage nurse also noted that Mr. Tolson was unable to move his left foot. Is it your opinion that that was an accurate statement by the triage nurse or not?
Objection.
I do not think that's an accurate statement.
Okay.
I think he didn't want to move his foot.
So you're interpreting unable to move the foot as to Mr. Tolson's conscious decision not to move his foot, but not an ability not to be able to move his foot because of some paresthesia or paralysis.
I'm sorry, can you say that again, Rodney? I lost your question.
Did you understand the question, Don?
Yes.
Okay.
And I don't, if one thinks about the movement of the foot, since we know that there was no injury to the foot, it's all in the knee. The fact is that one is able to flex and extend the foot without moving the knee, and clearly we didn't have that problem.
Okay. Why wasn't there a problem that prevented Mr. Tolson from being able to move his left foot, even though it's noted in the chart?
Objection to form. I don't even understand that question.
His pain, he didn't want to move his foot.
Okay, and that's why you conclude that he was unable to move his foot is solely because of the pain and not because of any other injury to his leg or foot.
The subsequent injuries do not in any way support the presence of a paralysis of the foot.
Would an injury to the nerves that run down the leg, if they were injured, would that result in an inability to move the foot?
If you had a peroneal nerve injury, you would have problems with the dorsiflexion of the toe, not the foot.
What injury to the nerve in his leg would result in the inability to move the foot?
You'd be talking about the tibial nerve primarily.
Is there a popliteal nerve?
There is.
Where does that run from?
The popliteal nerve is a very short nerve that is a branch off the sciatica that comes, and it's the short period before the develop. It splits again into the peroneal and the tibial nerves.
Is the popliteal nerve in the same area as the popliteal artery?
Yes, it is.
How close are they? Are they real close?
Yes.
Okay. And we do know that Mr. Tolson sustained an injury to his popliteal artery as a result of it being trapped in the fence, correct?
In retrospect, yes.
Okay. And because the popliteal nerve is so close to the popliteal artery, isn't it reasonable or probable that that nerve also sustained an injury at the time the popliteal artery was injured?
Objection to form.
The and this is kind of out of my area, but I have no indication that, that there was a traumatic transection of that nerve. There may have been blunt trauma to that nerve, but that would have not resulted in a paralysis of the foot.
When you said this may be out of your area of expertise, have you ever been qualified as an expert with respect to nerve injuries of a patient?
Not beyond what an emergency physician would be addressing.
Okay. If a vascular surgeon was of the opinion that the popliteal nerve was in fact injured in this case and accounted for Mr. Tolson's ability to move his left foot, you wouldn't disagree with that doctor's opinion, correct?
No, he has
To the
his,
hypothetical, go ahead.
he has his own opinion, and you just finished saying that he's a vascular surgeon, and whether a vascular surgeon wants to talk about neuro findings, that's their prerogative.
Okay. So do you know one way or the other for sure, within a reasonable degree of medical probability, whether Mr. Tolson sustained an injury to his popliteal nerve that could have accounted for his inability to move his left foot?
I think that he sustained probably an injury representing paresthesias that subsequently were found, but do I think that he had a paralysis related to that? The answer is no.
Okay. And do you know on the continuum of injury within your area of expertise, what is the severity of the injury that causes paresthesia versus the severity of the injury that results in paralysis?
Oh, yes. You know, paresthesia is a tingling sensation. So, for example, if you, whether you call it funny bone, crazy bone, we hit our ulnar nerve, and we get a tingling sensation that goes down to the fourth and fifth fingers. That's paresthesia. That is indicative of a minor injury, direct trauma to the nerve. If you have paralysis to the nerve, then paralysis is, at least in the situation we're talking now, is going to be permanent for the immediate weeks or months, and it's not going to improve.
Is paralysis synonymous with numbness?
No, absolutely not. Completely different.
Okay. When physician assistant Shaw assessed or examined Mr. Tolson, she wrote positive numbness. Did you see that on page 11?
I think that was history, but let me look. She writes numbness and paresthesias. You're talking up here in
You're right
the
there, doctor.
midsection.
Yes, you're
Yep.
right there.
That's,
Okay.
that is history. That is not physical examination.
Okay. Where is there paresthesia noted on the physical examination?
There is no description of paresthesias in the physical examination.
So your testimony that he had paresthesia is solely from his complaint of numbness and, I'm sorry, his complaint?
He complained that he had numbness and paresthesia.
Now,
The
sir,
physical examination, there is no detailed description on the presence of paresthesias or numbness.
how do you check for that, physician assistant? What are you supposed to do to check for that?
Well, paresthesia is basically, that is strictly by history. There's no way to test that. Somebody says, yeah, I feel tingling and pins and needles sensation in my extremity. So numbness is easily, you touch one area, then usually most people touch a corresponding area in the right leg and say, does it feel the same? And if they say, yes, it feels the same, then, or no, it feels completely different.
Is there a soft and sharp test for numbness?
Yes, there's certainly. If you really want to do a detailed neurological assessment, there is a difference between the pinprick versus the touch of a cotton swab.
Did Ms. Shaw perform that test?
Neither.
Was she required to do so?
No, I don't think so.
Why not?
Because I don't think that what we were dealing with here was indicative of a nerve injury. What I think she was focused on was the fact that we had a traumatic knee injury.
Plaintiff complaining of numbness and pins and needles to the physician's assistant who's about to examine him, and it's your opinion that the physician's assistant did not have to do a sharp or soft test
No.
for numbness?
No, I do not think that one would talk about, see whether the paresthesias fit anatomical distribution, and it's very rare that one would be doing a needle and cotton testing of somebody's sensory neurological examination of an extremity. I can't remember the last time I did it.
Isn't the numbness that's reported by the physician's assistant on page 11 consistent with Mr. Tolson's inability to move his left foot on page number 5?
Objection of foundation?
No.
Why not?
Numbness is sensory. Motor is paralysis.
Okay. What part of his leg was numb?
I can't tell you that.
Should the physician's assistant have noted that in the chart?
If she thought it was significant, she should have.
Why wouldn't that be significant, doctor?
You'd have to ask her that, depending on where she noted the numbness.
We just don't know from the chart, correct?
Correct.
Okay. Now, was Mr. Tolson's leg still in a splint when physician's assistant Shaw examined his leg?
Objection.
Well, it can't be when she says limited range of motion.
Who took the splint off of his foot, his leg?
I can't tell you that. Most likely it would have been her.
Okay.
And the reason I say that is because the nurses, if somebody comes in with a splint on, they leave it on.
They do. The person that's supposed to take the splint off would be the physician's assistant or the ER doc, correct?
Correct.
Okay, so at some time the splint came off his leg, but there's no evidence in the chart as to when that occurred or who took that off, correct?
You are correct.
Okay, so now, if Ms. Shaw actually took the splint off Mr. Tolson's leg and had done a stability test of the knee, would you believe that based upon what we know now for the injuries he sustained to the internal structures of the knee, that there would have been a positive finding for instability at that time?
I'm going to object because you laid a foundation that Dr. Bessent didn't review any of the subsequent records that speak about the injuries to his knee.
You know, correct me if I'm wrong, but you understood the results of the MRI from reading one of the deposition testimony, correct?
Yes.
Okay, now, so you do have that knowledge. So my question still stands. And actually, I'm going to have the court reporter to read it back.
Well, I can.
Unless you remembered it?
I-
Go
Yeah,
ahead.
and I'm just,
Go
I'm
ahead.
just going to re-raise my objection. Go ahead.
All right.
Go ahead.
Had the patient pain allowed and had the swelling allowed, I am comfortable that examination of the stability tests would have shown some degree of injury. And by that I mean, depending on which specific ligaments we were able to ascertain were injured, there would have been positive findings. Having said that, the more acutely injured the knee is, the less likely you are to get an accurate examination at that particular time, because there is too much pain, there's too much swelling. And the way I solve this problem in the ER is that I take the opposite knee, the uninjured knee, and I tell the patient that I'm supposed to move you in this range of motion, and I'm supposed to test your medial and collateral ligaments by stressing it. I'm supposed to check your anterior and posterior cruciate ligaments by drawer sign or Lachman's test. And they look at me and they said, "You're not going to do that to this knee, to the injured knee." And I say, "You're exactly correct." So, but usually I could say, I feel very comfortable that you have an internal knee derangement. An internal knee derangement is, since you're not making, I say, $150,000 every Sunday playing football, The fact is that we're going to treat you appropriately and get you off to the orthopedist for further evaluation and treatment of your internal knee derangement.
But if it was one of those people that make $150,000 a year playing football on Sunday, then would additional tests have been ordered at that time?
Not by the emergency.
Objection.
Not by the emergency physician. That would probably the professional football teams have their own orthopods, and those people would have come and seen the patient promptly, either there or in their office. In contrast, the reality of today is that the orthopedist, except for some specific injuries, usually have the patient splinted, and they see them in their office in follow-up.
If the examination of Mr. Tolson's knee by Ms. Shaw had revealed gross instability of the knee, would it be reasonable for her to have ordered an MRI at that time?
No.
Would it be reasonable for her to order any test other than an X-ray?
No, because the diagnosis of instability of the knee, as you call it, is consistent with internal knee derangement. The patient is going to need to be splinted, non-weight bearing, ice it down, analgesics, anti-inflammatory, and referral to the orthopedist for follow-up care. All things were done.
Now, we talked about the orthopedic examination of the knee, correct?
Correct.
How about the examination of the vascular stability of his leg?
The vascular stability is assessed by just palpating the pulses, and the areas that we would be interested in would be the popliteal artery. We would be interested in the dorsal pedis and the posterior tibial arteries. They're the three vessels that are amenable to palpation of the lower extremities.
Did Ms. Shaw palpate the popliteal artery?
The only thing I can say is at the time of discharge, she has checked that the neurovascular assessment was intact.
My question is, did at any time during the treatment of Mr. Tolson, Ms. Shaw palpate Mr. Tolson's popliteal artery?
All I can say is what I just said, that she has checked off the box that she has done this. Did she specifically write down that I have checked, ding, 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 ding? No, she did not.
Was she supposed to have palpated the popliteal artery?
That is correct.
Okay, so that should have been done during the initial examination of Mr. Tolson, correct?
It may have been done. I can't tell you that. Standard of care and documentation are two entirely different things.
But the standard of care did require her to palpate the popliteal artery upon her examination of Mr.
Attempt to
Tolson.
feel it, yes.
Okay. And there's no indication here that she was unable to do that in the chart, correct?
There's no indication she did it or did not do it.
There's no indication that she was unable to do it
No.
either? Okay. Now, do you have an opinion as, I know you're not a vascular expert, do you have an opinion one way or the other, if she had palpated the popliteal artery, what the results would have been?
Well, since at the time of discharge, it was present, I think had she palpated it, she would have probably felt the popliteal pulsations.
Okay. Notwithstanding that we know he did sustain an injury to his popliteal artery?
Yes.
Okay. Are you going to give any opinion one way or the other, how seriously the popliteal artery was injured, what time it was injured, the degree to which it was injured?
No.
Okay. Am I correct to say that you're then unable to give an opinion as to what, if any, decrease in the flow of blood happened to Mr. Tolson's leg as a result of any injury to his popliteal artery?
Objection to form.
Also, same objection.
No, I would not be, that would be a vascular surgeon. That would not be something I would be comfortable testifying about.
Okay. Is the palpation of pulses a reliable way to check the flow of blood into a person's extremity?
It's very subjective.
are there more reliable methods by which medical providers such as Ms. Shaw could have assessed the flow of blood into Mr. Tolson's leg and foot?
Objection to forming foundation.
One can use an ultrasound handheld at the bedside to assess flow, and you, in addition to just finding the vessel, one's usually able to ascertain how the flow is. So in other words, you get a good vessel gets real loud, and compromised vessel may give you a sound that's it's significantly different. It's much like when one palpates it. You grade it from 1 to 4. The ultrasound, people just say ultrasound present, but they can hear the difference. Then if you're really concerned, you could do an ankle brachial ratio.
And do you as a ER doctor know what the ankle brachial ratio would be that would suggest a injury or a decrease of flow of blood into the person's extremity from the results of that study?
Just from the results of that study, yes, I do, from the standpoint that not so much from the ER, but from my consulting work at Social Security, peripheral vascular disease, people that have ankle brachial ratios below 0.6 have significant peripheral vascular disease. So that's something that one would be concerned about in some situations, not an acute traumatic situation. I would, if I really thought that I was dealing with a dislocated knee, I would probably, one, do that study and have that information available to the orthopedist and vascular surgeon, since both are going to have to be actively involved in the management of this problem.
So if in this case, Mr. Tolson had been your patient and you believe he sustained a dislocation to his knee, would you have ordered an ankle brachial study?
You've got a real hypothetical there, because from the mechanism, I didn't think that that was a reasonable consideration, but had whatever had I thought that that I was dealing with any patient with a dislocated knee, I would have done such a study.
Now the x-ray did not reveal a dislocation at the time it was taken, correct?
Correct.
But that doesn't mean that the knee may not have been dislocated before the x-ray was taken, correct?
Correct.
Okay. So you can't rely upon an x-ray study to make a determination that the person did not have a dislocation of his knee before the x-ray study was done, correct?
Correct. There's cases where there's spontaneous reduction.
Have we discussed all of the aspects of the physical examination that you believe Ms. Shaw should have performed on Mr. Tolson?
Yes, we already went through that.
Okay, let's go now to the reaching of a differential diagnosis. For a differential diagnosis means that, and you can correct me if I'm wrong, the physician has to consider if there's more than one explanation for the person's injury and more than one cause, then the physician is obligated to explore those reasons to reach the diagnosis.
Reasonable explanation require reasonable workup. The answer is yes.
Okay. And what is the reasonable differential diagnosis that you believe the standard of care required Ms. Shaw to reach in this case?
In this particular case, I think it's actually pretty limited. That my differential would have been that we have a contusion to the knee, we have a sprained knee, we have an internal derangement of the knee, we have a fracture of one of the bones of the knee.
But not a dislocation.
I see nothing, from the description of the history, and even now a barrier gate going up. It is very difficult to understand how this gentleman's, in my mind, I still don't understand how he sustained a dislocation of his knee.
And I don't know if I asked you this question, but do you now agree that he had a dislocated knee in retrospect?
Objection?
I think in retrospect, it is reasonable to conclude that he sustained, however he did this, he sustained a dislocated knee.
So what is the differential diagnosis that Ms. Shaw should have reached?
Exactly what I just went over.
If Ms. Shaw was unable to perform a thorough orthopedic examination at 4 o'clock in the afternoon is when she first saw him, was she then obligated to perform the orthopedic examination after he came back from x-ray, which we know he didn't have a fracture to his knee, no dislocation at that time, and after his pain level was reduced significantly?
No, I don't think so, because in this particular case, when the films came back, we knew that we had an effusion. An effusion in the presence of a traumatic injury is, I think, synonymous with an internal knee derangement, so there was no point putting the patient through any type of examination that would result in pain, further injury, and would not in any way alter the subsequent course of action required.
So, it's your opinion if Ms. Shaw had performed a thorough orthopedic evaluation after Mr. Tolson came back from x-ray, after his pain was reduced almost to 0, that whatever that evaluation would have revealed, it would not change the course of treatment for him?
Exactly.
And if she was unable to perform a complete vascular examination, and had performed a complete vascular examination after he came back from x-ray, do you believe that the course of treatment would still have been the same?
Objection, foundation informed.
Foundation informed.
Well, first of all, I think she did do a vascular examination, neurovascular, because not only she, but the nurse said it was intact prior to discharge. But there was one with an internal knee derangement. One does not usually think of ischemic injury to the lower extremity secondary to popliteal injury in a non-penetrating event.
Did the neurovascular examination at the time of discharge require an examination of the popliteal artery?
Probably not. Probably one would be more concerned with the vascular supply to the lower extremity, because if you've got good vascular supply to the lower extremity, by and large, it's not unreasonable to conclude that the proximal vessels are also working properly.
So, no doctor or physician's assistant had to check the popliteal artery before Mr. Tolson was discharged? Is that
No.
your opinion?
That's my opinion, because
Okay.
the distal vessels were intact.
Okay. And how do we know that from the chart? At the time of discharge?
The time of discharge,
Right.
the box that says neurovascular, post-splint application neurovascular assessment performed and intact. KS, which is the nurse, she assesses that, and also Dr. Shaw says that she did this also.
From the chart, do we know if either the nurse or Dr. Shaw palpated the pedal pulses upon discharge?
All I can say is it's checked that they did.
Well, the box is checked.
But they did
But but let me finish. The box regarding the neurovascular check is checked, but there's no specific notation in the chart regarding the checking of PDO pulses. Would you agree with that?
I would.
Okay. Now, at the time of discharge, and at the time of Ms. Shaw evaluated Mr. Tolson, was she required to check to see if Mr. Tolson's foot was cold?
Objection to form and foundation.
Same objection.
I think she was, and I think she indeed, if you go back to page 11, under cardiovascular, specifically denies cold extremity.
Was there any notation at time of discharge, similar notation in the chart at time of discharge with respect to the temperature of Mr. Tolson's left foot?
No, there's no description of that. One, I think, would assume if you've got good vascular supply, your temperatures, there's no compromise of the vascular flow, so there would be no need to document that the temperature is normal.
Would one also reasonably assume that if the foot was cold, then there would be a compromise of the vascular flow into the foot?
Objection to form.
It is possible.
Is it probable?
Objection.
Depending on whether they ice down the ankle and foot, lacking external ice to the area, one would be concerned about vascular supply in anybody that you're sending home with a cold foot.
Okay. And in this case, there's no evidence that Mr. Tolson's foot was ever iced down, correct?
No evidence one way or the other.
Okay. So if any nurse had touched Mr. Tolson's foot, or physician's assistant or doctor had touched Mr. Tolson's foot after he got back to the examining room in the hospital and detected that his foot was cold to the touch, would then they be required to do a further neurovascular examination of his foot at that time?
Objection to the extent that you included nursing in that. You're asking for a standard of care opinion from the doctor who's just testified. He's not testifying regarding nursing.
Objection to form, foundation, and hypothetical.
You can answer, Doctor.
Had we found that when we touched the patient, the foot was cold, I would want to know what the pulses were when we found that the foot was cold. And yeah, I think that I can't disagree that one would have to give some thought to exactly what was going on with regards to the foot at the time of discharge.
Okay. Now, were you provided with Mr. Tolson's sister's deposition, Corey Tolson?
No.
Okay. I'll tell you from Miss Corey Elaine Tolson's deposition that she actually put her hands on Mr. Tolson's foot when the family said a prayer on it and felt that the foot was cold. Then a nurse came in who was doing the vital signs, and Mr. Tolson explained to that nurse, "My foot's cold and I have no feeling in my foot." According to Miss Corey Elaine Tolson's testimony, the nurse told Mr. Tolson in her presence, "I will tell the doctor." Okay. Assuming that that is the evidence in the case, did that nurse then have the obligation to convey those complaints to either the physician's assistant or Dr. Jackson?
Objection.
Dr. Bessent, you don't have to answer that because we've already established that you don't have any opinions on nursing standard of care, and you haven't been asked to review this case on that issue, so you don't need to answer that. You can move on, Rodney.
Are you going to instruct him not to answer the question?
Yeah, with the foundation that you've laid that he's not going to be testifying at trial on nursing standard of care and doesn't have any opinions in that regard.
Doctor, if that same nurse had told physician's assistant Shaw or Dr. Jackson, "I just came from Mr. Tolson's office. He told me his foot was cold and he had no feeling in the foot," what would the standard of care be required of either Ms. Shaw or Dr. Jackson if the nurse had conveyed that information to them?
Objection.
To object to the form, foundation, and the hypothetical. Go ahead.
It would have required an assessment of the patient's current status.
And can you tell me what the nature of that assessment would have been?
It would have basically gone in and done exactly what we talked about before. We would have gone in, elicited a history of what exactly was bothering the patient. We would have done our physical examination. We would have thought about the differential diagnosis as it relates to that particular complaint, and then what do we have to do to assess this problem. So every time we get a complaint, that's what I like about my assessment, is I drop back to my 8 steps and would assess the patient again using those 8 steps.
Okay. If on that assessment, either Dr. Shaw or Ms. Shaw or Dr. Jackson had found Mr. Tolson's foot was cold, but still had positive pulses, would then you go to the next step for the Doppler or for the ankle brachial index to check the flow of blood going to his foot?
Objection, foundation, go ahead.
Depending on how cold the foot was, what other findings might be present, then I might have gone back and reassessed exactly what, my thought process of the whole evaluation of this patient.
And if the foot was cold, actually cold to the touch, even though there was some positive pedal pulses, would then the next step be required to do a further evaluation of the flow of blood into his foot?
If one thought we were dealing with compromise, of the vascular system, the answer would be yes.
Okay. And would that indicate a compromise of a vascular system, those complaints?
Possibly.
Objection.
Same question. If upon discharge, Mr. Tolson complained of a cold foot and he had no feeling in his foot, if he told the nurse on discharge of that, and if he had conveyed that to Nurse Shaw, let's talk about Nurse Shaw.
PA
I'm
Shaw.
PA
There is
Shaw.
no nurse
Thank
Shaw.
you. If at the time of discharge, Mr. Tolson told PA Shaw, my foot's cold, I have no feeling in it, would she be required to do the same assessment that you just talked about?
And object to the form and foundation and the hypothetical, because there's absolutely no factual basis for that question.
Actually, there is. It's his own testimony. Go ahead, Doctor. You
It's
can answer.
not, go ahead.
All right. If in the hypothetical or actual, whichever way, you guys can argue that, the fact is that at the time of discharge, had we had those specific complaints, Ms. Shaw, PA Shaw would have, I think, reasonably been required to address those concerns and decide whether further evaluation was warranted or not.
And if she failed to do so, would that be a breach of the standard of
Same
care?
objection.
If the patient says, this is a problem that I have now, she would have been required to address that specific issue. The answer clearly would be then she would have deviated from the standard of care.
Now, have we discussed all of the opinions and factual basis for the opinions that you have with respect to physician assistant Shaw?
I think that you covered it adequately.
All right. Let's talk about Dr. Jackson.
Certainly.
Okay. Is there any indication in the medical chart that Dr. Jackson physically examined Mr. Tolson?
Her comment is, patients seen with PA agree with care. One could argue what the word seen means. Does one look at that and say, I was in the room when the PA examined the patient, or in the context of how medical professionals, the patient was seen, that in that context, one usually means the patient had a history in physical performed.
Well, it said patient was seen with physician's assistant.
With
And
PA.
one context would be that the physician's assistant is the person that saw the patient.
Objection.
Is that one context?
So you've already
Objection.
used the word see there, and I'm not sure how you're using it. Again, like I said, I can't tell you, to my looking at this, patient seen with PA indicates that the physician examined the patient. But at the same time, I can appreciate how lay people would say you know, I was in the room and I watched the PA do the examination, I guess that's possible interpretation of that also. But then I would question, well, why do you stand there and watch the PA do the examination? You should be off doing something else.
So the only place in the medical chart that reflects that Dr. Jackson may have actually examined Mr. Tolson is on page 16, where it says, patient seen with PA, correct?
Correct.
Now, also on page 16, the hospital provides a box for the emergency room doctor to check, where one of the boxes says, I personally interviewed, examined, and participated in the care of this patient. Dr. Jackson did not check that box, did she?
It's not checked.
Would you expect if she did that, then that box would have been checked?
Did what?
Did personally interview, examine, and participated in the care of the patient.
Objection?
That is a box that's supposed to be checked if she did that.
Objection as to supposed to be checked, but go ahead.
You'd have to ask her specifically, and I don't recall whether you did or not, whether she checks that box or just writes patient seen with PA. I can't, you know, the box is there. Had she checked the box and she had done those things, then you would not be questioning her evaluation of this patient.
So that does bring into question whether or not the evaluation occurred because the box has not been checked, correct?
Objection?
It brings into question the documentation of this file, and it clearly is not checked.
Okay. Did the standard of care require her to check the box if she actually personally interviewed, examined, and participated in the care of the patient?
No, I already told you that standard of care and documentation are entirely two different things.
And is the opinions that you're going to give based upon your own practices in the emergency room where you work?
Well, it's certainly based in a large degree upon what I do in the emergency department, yes.
Is there a similar form at St. Joseph's Hospital for doctors such as yourself to check a box that indicates you personally examined, interviewed, and participated in the care of the patient?
In 2009.
In 2009, I do not recall this, and in fact, I usually, when I do have to supervise PAs, I write down patient was seen and examined. That's usually what I say with the PA, or I've seen and examined this patient and agree with the treatment.
When an emergency room doctor does a full and complete examination of the patient, is that doctor's findings supposed to be contained in the chart?
Well, if one is independently doing it, the answer is yes, you want to do this. Having said that, you know, when I started practice, the orthopods used to come in and write knee derangement. I mean, that would be their entire shtick, or fractured ankle, fractured lateral malleolus. These days, we don't do things like that. We have better documentation. The poorer your documentation, the more difficult it is for you to prove that you met the standard of care. But as far as having a physician write down everything that they do in an examination, that stretches one's reasonable thought process, because we just simply don't do it.
So is it your opinion that in this case, that when Dr. Jackson, as she testified to, performed an examination of Mr. Tolson, she was not supposed to write in the chart any of her findings whatsoever?
She didn't have to. If she examined the patient, she met the standard of care, and it'll be up to the jury to decide whether she actually did all the things that she said she did.
Isn't the noting of a hospital chart with respect to the findings upon examination of a patient part of the standard of care?
No, it's not.
So in this case, if we follow your opinion to its logical conclusion, physician assistant Shaw didn't have to make a single notation in the chart after her examination of the patient. Would that be true?
She does not have to make an examine. She does not have to write anything down to meet the standard of care.
Wait a second,
Yeah,
he said
yeah.
Kruppa Shaw.
Yeah.
Yeah, I know
That's-
she did.
Okay.
So your
It
answer
was
still...
hypothetical.
Oh, okay.
Yeah.
We were in a hypothetical.
Right. So your opinion is, and it will be when we go to trial, that when a physician assistant examines a patient in an emergency room, the physician assistant is not required to write anything in the chart regarding her examination.
That is, the standard of care is the standard of care. You're required to meet the standard of care, to fulfill it, to meet the obligations you have for, to the patient. Documentation of care, documentation is completely separate and distinct. There's some people that are very good clinicians and very poor documenters. Other people are perhaps aren't the best clinicians, and they document, exceptionally well. The two are related, but they're not synonymous.
In this case, if Ms. Shaw had not made one single notation in this chart regarding the examination, diagnosis, care of Mr. Tolson, you would still come into court and tell the members of the jury that she complied with the standard of care.
What I would do, and it's what I do when I go into court, I tell the jury, I said, and I'm very specific about this, I said, listen, I read the depositions. I don't decide who is telling the truth or who is not telling the truth, because otherwise I'd be sitting in the box with you. I try to give you the tools, and the tools I give you are the 8 steps, and then you have to decide whether that individual provider has met those 8 steps. The more you document, the better it is to convince those people in the jury box that you did do those things. If Dr. Jackson comes in and says, I did these things, I did all these things, I do it on everybody, I remember this patient because, and she outlines the reason she would remember this patient, and then it's up to the jury to decide whether she indeed did those things or not. And